The next paper is from Fiona Kerray, evaluating the evidence for the impact of human factor science on operative performance in vascular surgery.
Vascular and endovascular surgery are characterised by complex patients, an urgent and multidisciplinary workload, and often challenging interventions which involve novel technologies. The outcomes are the sum of patient, individual, person, equipment, environmental, and organisational factors. When leveraged effectively, these can optimise performance, enhance well-being, and improve safety. Human factor science, ergonomics, or HFE, is the scientific discipline that looks at the interaction between these different aspects of our socio-technical work system. It draws on knowledge from several other different areas, but the Chartered Institute of Ergonomics and Human Factors has summarised 67 and organised them into these 5 categories, and I'll use these categories to structure my review. So the primary aim of this narrative review was to synthesise, appraise and summarise the literature describing the impact of human factors science specifically on operative performance in vascular surgery. The secondary aims were to identify key areas that could inform education, research and training. So a systematic search strategy was developed. However, due to the broad reach of the topic and the spectrum of definitions that HFE attracts, it was accepted that retrieved papers would be a representative sample only and not an exhaustive data set. A total of 2,080 studies were retrieved, of which 107 had a full text review. 14 studies met all of the inclusion criteria. The principal reason for not being included was the primary aim not being related to operative performance, and it should be noted that 6 were excluded due to being related to simulation. So results were extracted according to a predefined pro forma. The median number of years since publication was 3, and all of the studies were from either Europe or North America. Only 1 systematic review was included. Studies which looked at anatomy and physiology knowledge areas also looked at their interaction with work environment, therefore these categories were combined. And there was 1 study that considered knowledge areas from anatomy and physiology and psychology, therefore it was considered under both headings. So looking first at anatomy and physiology, these studies use subjective and objective measurements to characterise postural risk and work-related pain in vascular surgery. They found that the neck and the lower back are most commonly affected. The adjuncts such as loops and headlights can exacerbate this, and that there's a lack of professional education on how to mitigate these risks. And also that there's a high prevalence of work-related pain in vascular surgeons, and many of these people are accessing medical care because of this, if not taking time off work, if not leaving the profession early. So there's a need to curate our workload from an early point in our career. The first paper included under psychology was also included under anatomy and physiology. It was a survey. They found that 85% of their respondents were professionally satisfied, but despite this, 40% reported feeling burnt out at work at least once a week, and there was a relationship between burnout and pain scores. Lear and colleagues found that vascular surgeons perceive knowledge, skill and competence to be more related to adverse events in open operations compared to organisational structure for endovascular. And 2 studies looked at the implication of a pre-existing do not attempt resuscitation form on perioperative decision-making. They found it to be an independent predictor of mortality and suggest that this should be included in perioperative counselling for informed consent. In this category, Pareska and colleagues developed a novel team familiarity score. They demonstrated that a 10-fold increase in familiarity can result in a 19% reduction in length of procedure. And they also found that emergency aortic procedures were more likely to be performed by less familiar teams. They suggest that their results could be used to plan theatre lists to improve efficiency, but also potentially to select team members to produce the most effective teams for specific operations. The other 3 studies in this category looked at different types of failure. They found that although equipment failures are common and associated with more errors, communication failures are significantly associated with major errors and harm. There was also a trend that there is a higher number of failures in endovascular operations compared to open, and therefore bespoke different approaches will be required for each of these in order to reduce error. And finally, methods and tools. So this category considered knowledge areas such as data analysis and classification, evaluation of work activities and study design. Doyen and colleagues demonstrated how the introduction of an operating room black box could be used to assess safety and radiation practices, and also measure technical and non-technical skills. And Beck and colleagues used the results of their narrative review, their literature review rather, and the results of a study that they designed to create a novel endovascular rating scale. So in conclusion, we can see that human factors science is intimately associated with all aspects of performance in vascular surgery, and there's an evolving body of evidence to demonstrate this. If we can harness this knowledge and integrate knowledge areas such as postural risk and behavioural safety into education and training, then we have the opportunity to optimise individual and team performance, enhance well-being, and improve safety. Thank you.
First question, really interesting that team familiarity improves outcome. In our acute list, we have a different anaesthetist every week. How did you define familiarity? Was it, they'd worked together for a week, they'd worked together for a month, they'd worked together for a year, or, how was that defined?
Yeah. It's a good question. I should be clear that it didn't improve outcomes. It reduced the length of operation. So there wasn't actually an association. They couldn't demonstrate an association with, for example, the Clavien-Dindo score. However, to answer your question about how it was defined, so it was Kat Pauska, one of my registrar colleagues, and her team. So they looked at the total number of interactions between the different team members over a 6-month period compared to the total number of potential interactions they could have had. And they developed an equation that made that into team familiarity.
Sorry, over what period?
I think it was 6 months.
Okay.
Hi. It's a beautiful summary of the evidence and what they talk about, but you haven't actually talked about the quality of evidence. Can you talk to that a bit, please?
Yes. So because the nature of the study is that obviously it's a very heterogeneous pool there, so we couldn't do a proper quality analysis. Generally speaking, though, the studies were of, in my opinion, quite low quality, so there were quite low numbers. For example, in the surveys, they had a response rate of sort of 20%. The systematic review only included 8 papers, and the 2 papers at the end were just descriptive papers. So I think what this does is demonstrate the presence of human factors science. It opens up the discussion for how it is relevant to vascular surgery, but clearly, further, more targeted, specific, and higher quality studies are required.
How do we bring this into the operating theatre?
Yeah, so I think there are 2 ways in which we need to do this. The first is through education, and the second is through actually actively applying some of these things that we've seen. So in terms of education, we've already worked with the Vascular Society to bring human factors education into the Aspire programme, having done a needs analysis to assess baseline knowledge and actually what people would want from a programme to make sure it's relevant and accessible. And then in terms of using some of the techniques that you see there, so things like surgical sabermetrics, it's an evolving field which uses data analytics and video. So it sort of complements traditional things like the NSTEP and the NVR, and then it gives you individual performance metrics that you can then apply. So things like that I think will come along.
If you're introducing into the SPY programme, you're only targeting trainees. What about how are you going to target consultants?
Yeah, that's a great point, and it was one that was raised yesterday as well. I think that the consultant body is a slightly different beast to the trainee body, just due to their previous experience and the sort of biases that they'll bring with them about what human factors actually is. So part of my work, I think, is about breaking the stigma of human factors, removing the jargon from it, and making clear about what it is. And so to bring it into the consultant body, I think that will be one of the first things that we need to do. And then we'll need to do a further sort of needs analysis again to see what their baseline knowledge is, what their understanding is, and what they would want, what they feel is relevant to them.
So a question from Slido that clearly has personal relevance. Can the physical problems such as back pain be prevented effectively?
Yeah, that's a great question. So Susan Holbeck is a professor of ergonomics at the Mayo in Rochester, and she's done some wonderful work on this. She very kindly agreed to be interviewed for one of my podcasts that I did. And she's demonstrated that, through appropriate posture in theatre, you can reduce this. She's also given a little... their team have made this thing so that you can introduce these mini exercises into operations, which again will reduce your incidence of back pain. And also using adjuncts, like we call it the princess pad, but actually it's an anti-fatigue mat. There shouldn't be a barrier to using that. These are real opportunities to reduce back pain.
Alan Davis.
You commented on it, but could you just clarify for me that you were suggesting that the wearing of loops were actually bad for your posture?
Yes, so again, it's Susan Holbeck's work. So what she's demonstrated is that loops can exacerbate neck pain and lower back pain in some scenarios.
No, that's fine, because I'm not a believer in wearing them, so that's fine.
There's a great debate in Scotland about that. I could borrow your opinions.
Do you think there's a role for coaching in theatre? Atul Gawande wrote a great article on this from Beck's Winterbottom.
Yeah, absolutely, I do. And again, one of my colleagues at the Edinburgh group, Edinburgh Surgical Sabermetrics group, is doing some great work on peer-to-peer coaching at the moment. And it, I think this is something that we're going to see. It's already been introduced in America, and it is something I think will roll out in the UK as well. We sort of become a consultant, and then we don't get any more formal education and training assessments. And actually, peer-to-peer coaching is a really valuable tool to introduce in that context.
Okay, thank you very much.
Thank you.